No, I agree with you because of multiple reasons. Hey, Dr. Dries, if you want to say hi. We have a minute or two.
Hi, Beverly Biller. Nice to meet you.
She was the person I was telling you about, the former dean. Yeah.
Well, I'm excited to be here. It's always interesting when anything is put simpler. You always gain something from it. And sometimes it's just a matter of, well, how do you express this? That makes sense.
Oh, now we can start. All right, I will give it one more minute, everyone.
So at our hospital, we also have run-arounds at home. And what that means is amazing. People look at their watches in their offices and clinics and think, oh, maybe I should walk over to grand rounds now.
In my house, I try to be a stickler in time, but that's challenging with two daughters. Well, welcome everyone. For the sake of time, I'm going to go ahead and start. So it's my great pleasure. This is the Mark Dodge Lectureship, which was it's a very important aspect of our yearly endocrine. So I want to speak briefly about Mark Dodge, Dr. Dodge, and then, of course, about our esteemed guest, Dr. Biller. So Dr. Dodge was a graduate of KU Med School in 1941 and went to residency and then was a active physician in St. Luke's. And he did something, he was an endocrinologist before there was board certification for endocrinology and went back and took the exam for endocrinology at age 59. And he did very well. And through his efforts and his friends and family, they created this wonderful grant or scholarship in 1977 to allow us to bring in the leaders of the field of endocrinology. And there is a list of them, and these are definitely like the individuals who write for all the major texts. That leads me to Dr. Beverly Biller, who is a professor at Harvard and the program director for the Endocrine Fellowship at Mass General. She asked me to keep it short. So basically, she is a prominent leader in the neuroendocrine field and has published over 200 publications. And if there's a guideline that you read in pituitary disease, she probably wrote it. And that's it.
Thank you so much for making it short. This lectureship is really quite amazing. It's 3 days and 4 lectures at hospitals throughout Kansas City on both sides, both states, I guess. It's a really special thing that it provides for people to get together and hear about endocrinology. Those of you who are endocrinologists, I was actually asked to target this for a general medical audience, so you need to answer some emails or whatever, I won't be offended because you probably know most of what I'm going to say. I do want to also highlight Dr. Dodge. I have learned quite a lot about him, and so I kind of listed the 8 things that grabbed my attention the most that you see here. That he was a master clinician, a passionate educator, a naval flight surgeon, husband, father, and grandfather. He was also an apple tree farmer. We saw a picture of him on his apple farm last night at a dinner, and a beekeeper, which is kind of interesting. I also need to mention that the person who invited me, Dr. Leland Graves, unfortunately passed away between when he invited me and today. And he and I had corresponded over many years about interesting pituitary cases. So I'm grateful that he suggested me for this amazing lectureship. Your hospital also said I have to show this disclosure slide, although I had already made my own disclosure slide showing you research grants and consulting honoraria, and also if any investigational agents come up, that will be stated on the slide. So some of you may try to remember, where exactly is the pituitary gland? I'm really fortunate. I spend all of my time, my patient care, my research, thinking just about disorders of the pituitary. So just to remind you, it sits in a little pocket of bone called the sella turcica, which came from the early anatomists thinking that looked like a saddle that the Turks apparently rode on their camels, maybe? So that's that little pocket of bone behind the sphenoid sinus and behind the nose. I like to think of it as the conductor of the endocrine orchestra. If you look in the textbooks, it will say it's the master gland. For a number of reasons, I just don't like that term. So conductor of the endocrine orchestra is a term that was coined almost a century ago by an Irish endocrinologist. And when I heard about it, I thought, that's the right term, and I'm going to tell you why that is. So remember that the pituitary gland is controlled by the releasing and inhibiting factors made above in the hypothalamus that travels down a special system of blood vessels called the portal vessels that you see here, and which then reach the pituitary gland, triggering release of the many pituitary hormones. And they travel to their target organs, which are the glands, like the thyroid, the ovaries, and so on, that they control. And if the usually pulses of hormones.
They can't hear at Bruce. Can we get the mic closer? They can't hear on us.
They can't hear. Can we get the mic closer? I don't know, you tell me.
I can also hear
Okay. I'll talk for a little bit and you can tell me what you're hearing as to whether it's better. Okay. So the glands receive the pituitary hormones flowing by, and that tells them to make their hormones. And I think when everything is going smoothly, it's like beautiful music. But there are lots of ways there can be problems with the pituitary gland. And I kind of think of them in 3 categories, and that's how I talk to patients who may have a pituitary condition. There can be a group of cells in the pituitary that's making too much of that hormone, usually a benign pituitary adenoma, and we'll talk about some. There can also be deficiency from a whole host of reasons, a cyst, a bleed, a tumor leaning on the normal pituitary, so we can have too little. And then if there's a large lesion in the region of the pituitary, a meningioma, a craniopharyngioma, a big pituitary tumor, the normal gland can be compressed. And it can start to push on other structures nearby. Right above the pituitary is the optic chiasm, and on the sides of the pituitary in the cavernous sinuses are cranial nerves that control some of the muscles to the eye and the face. And so if we think about the too much category, which is mostly what I'm going to talk about, we can classify it according to which type of cell in the pituitary gland is making too much hormone. If it's the lactotrophs that make prolactin, that produces a prolactinoma. If it's the somatotrophs, the cells that make growth hormone, then we have acromegaly. If it's the corticotroph cells that make adrenocorticotrophic hormone, the adrenals are signaled too strongly to make cortisol, and that's Cushing's. And if the thyrotrophs are overdoing it, it's a very rare cause of hyperthyroidism. There are also cells in the pituitary gland that make luteinizing hormone and follicle stimulating hormone, the gonadotropins. But if they create a tumor, there's not a hormone excess state except for very, very rare case reportable situations. Usually those are called non-functioning tumors because the patients don't present with a symptom, a syndrome of hormone excess. So I'm going to focus on the hormone excess states. Many years ago, we looked at the various subtypes of pituitary adenomas to sort of figure out how many of each there are. And by far, the most common is lactotroph adenomas or prolactinomas. So if you walked into our waiting room in our pituitary center where there are 15 endocrinologists doing nothing but seeing pituitary patients, and there were 10 people, you could say probably half of these people have a prolactinoma. And so let's start with talking about that, since that's the most common. Now, you may think to yourself, why, if I'm not an endocrinologist, would I need to know anything about a prolactinoma? Well, I would say if you see women patients, there's a good chance that one or more of them has a prolactinoma, because you can see that almost 20% of women who stop having periods have a prolactinoma as the reason. And in fact, if she also has milk production, there's almost an 80% chance that she has a prolactinoma. So this is the most common type of pituitary adenoma. I'm just going to tell you quickly about a case and bring up some cardiology issues that came up related to this particular condition. This was a 28-year-old woman who was referred by her primary care provider because she had a prolactin that was about 2.5 times the upper limit of normal. This had been drawn because her periods had stopped for 8 months. She actually didn't mind that, the convenience of not having periods, but she knew there was something wrong, so that's why she went to see her PCP. She's very healthy, she's not taking any medications, there's no family history that's relevant, and she had a normal physical exam, except that she also had milk production. And so this patient brings up kind of our bread and butter condition of hyperprolactinemia. And you can see that there's a whole host of symptoms because both men and women can develop this condition. But in her case, her symptoms were amenorrhea and galactorrhea. She didn't have some of the other things that you see listed here. So what is the next step? Well, we always like to say the first rule of an abnormal lab test is repeat it. Could have been wrong, could have been a different patient. And then we have to think about all of the other things that can raise prolactin. Pregnancy is the physiologic reason prolactin should go up, because high prolactin prepares the breast for lactation when a woman delivers a baby. Primary hypothyroidism can also cause hyperprolactinemia. And then there's a long list of medications, many psychiatric medications, that can increase prolactin. And then there's another long list of all sorts of miscellaneous things that can raise prolactin. So here you see the physiologic causes and then the drugs that I mentioned. And then, of course, if there's a tumor making prolactin, or if there's a tumor in the pituitary area that can raise prolactin, even if it's not a prolactinoma. And then, as I mentioned, there's a whole host of other things that can do it. Anything that relates to the chest wall where the nipples are innervated can trigger a release of prolactin. And so if the prolactin is high again, and we rule out all of these things, so it's not a secondary cause, then we need to look at the pituitary gland because we need to see if there's a lesion that's making prolactin. And so here is her scan, and this is a coronal view with the patient looking out at you so that the left side of the picture is the right side of her head. And you can see with that helpful green arrow pointing right at it that there's a hypolucency, meaning a darker area on the left side of the pituitary. It's pushed upward a little bit, the top of the pituitary, but it isn't touching the optic chiasm, which is the horizontal line that you see here. You see there's only a few millimeters of space, so it doesn't take much growth to start to impact someone's vision, most typically loss of peripheral vision if there's compression of the optic chiasm. So we have a spot in the pituitary that isn't too big, and we have a woman who has amenorrhea that she doesn't mind and milk production. And so the question is, do we need to treat this? So prolactinomas are different from other pituitary adenomas because, as you'll hear in a few minutes, if someone has acromegaly or Cushing's, they need to be treated because those diseases raise mortality. But that's not true of prolactinomas. And so patients don't necessarily need to be treated unless they have one of these things. If the tumor has already grown to 1 centimeter or larger, our reasoning is it's clearly growing. We need to do something about it because it's going to continue to grow. If the patient has hypogonadism, which I'll come back to, if the high prolactin was found in the workup of infertility in either a woman or in a man, of course we would treat it since their goal is to be fertile and prolactin can interfere with that. Or if they had a small tumor, but over serial scans, it's been shown to be enlarging. Just the presence of galactorrhea by itself is not an indication for therapy. Although women are certainly anxious when it happens, we usually reassure them that this is a physiologic response to their high prolactin. And we don't generally treat just for galactorrhea unless it's interfering with the person's life. If she's running a board meeting, standing in front of the room and leaking through her suit, then, that's interfering with her life. We would treat that. There are natural history studies which show us that if you don't treat patients with small spots and high prolactin, 80% of the time, nothing changes. The lesion stays the same, the prolactin stays the same, and nothing bad happens. In fact, 10% of the time, the lesions go away and the prolactin falls to normal. So that leaves, if you're doing the arithmetic with me, 10%. 10% of patients will progress, and those are the patients who need to be treated. So if we elect not to treat a patient because they don't have an indication for treatment, we do follow them to make sure they're not those 1 in 10 people who will later need to be treated. In this case, though, the patient had hypogonadism. Now, I've told you a couple times that she didn't mind not having periods, but it isn't healthy for many reasons, and here's one of them. It substantially impacts bone density to have hyperprolactinemia and amenorrhea. These are some data from many years ago where we looked at a series of women who had prolactin levels in the same range as she did and measured their bone density, comparing it to age and, females. I was going to say age and sex match, but they were obviously all females. And the green bar is the normal range. So look how many of these women in their 20s and 30s have really low bone density, the kind of bone density you might expect in a 70 or 80-year-old woman. And in later studies, we were able to show that if you treat the hyperprolactinemia so that the periods come back, bone density goes back up to where it was. So that's why that's an indication for treatment. What are the treatment options? Well, the mainstay of treatment is to give a dopamine agonist. We very, very rarely need to do surgery anymore. That was done in the 70s and early 80s, and almost never have to give radiation unless it's unusually big or aggressive tumor, which fortunately is quite uncommon. And so the treatment is really interesting because it's based on the physiology. So prolactin is different from all the other pituitary hormones. All the other pituitary hormones are primarily under stimulatory control from the hypothalamic hormones. As the hypothalamic hormones slow down, all of the other pituitary hormones are released in pulses, but prolactin is under predominantly inhibitory control, with dopamine coming down from the hypothalamus, down the stalk, to inhibit the production of prolactin. So anything that prevents that, which could be a big cyst leaning against the pituitary stalk, will raise prolactin. So medical treatments were developed in the 1970s to mimic the natural inhibition. You wouldn't use dopamine because the patient would have to walk around with an IV because its half-life is so very short. But oral dopamine agonists have been developed to mimic the natural inhibition and keep prolactin down. And there are now several of them, but most typically in the United States, we use either bromocriptine, which was developed in the 70s, or cabergoline, which was developed in the 90s. And she was indeed started on a low dose of cabergoline, just half a pill a week. It's a very long-lasting drug, so you can just take the pill half a pill a week, and that brought her prolactin down to normal. She wasn't thrilled, but we went through explaining why that was important. And her periods became regular again. And so that provides her with bone protection. In addition, the little spot on her pituitary gland kind of melted away, and that's because these medicines are tumorostatic. They shrink the cytoplasm. They don't actually kill the tumor, but they decrease the size. And so this is a very typical case, but she was seen in 2006 initially, and then at the beginning of 2007, our field kind of had a shock, which is that there were 2 New England Journal of Medicine papers published in the same edition that showed that dopamine agonists were associated with valvulopathy in patients with Parkinson's disease treated with very high doses of dopamine agonists. And so, of course, we got lots of calls from our patients who read, the news blurb about the latest New England Journal information. And subsequently, many studies were conducted in hyperprolactinemic patients. What's the possible mechanism of this? So the pathology was found to be plaque formation along the valve leaflet surfaces and around the chordae tendineae. And this is thought to be due to serotonin 5-HT2B receptors that exist on the cardiac valves. And there are in vitro studies that show activation of 5-HT2B receptors activate a whole mitogenic pathway, and that leads to fibromyoblasts proliferating and the valvulopathy. And you can see here on the right the sort of laying down of fibrosis. And that's thought to be the mechanism. And this is very similar to heart lesions in carcinoid heart, and also what was many years ago fen-phen valvulopathy. In fact, at the time, the FDA withdrew approval for Pergolide because in these Parkinson's studies, that seemed to have the highest rate of the valvulopathy, whereas bromocriptine actually has the lowest rate. So they left bromocriptine and cabergoline on the market. We were worried though, and so we did a study that I'll describe briefly here. We looked at 100 patients, both men and women, who had been taking cabergoline for hyperprolactinemia for at least 6 months, and we compared them to carefully matched controls that were in the Mass General database of echocardiograms. And the bottom line is we really didn't find anything of concern. And we also looked at whether dose, either duration of dose or cumulative dose, correlated with any regurgitation, and it did not. At the time, we said, this is a good start, but more studies are needed. And since then, many studies have been done around the world. And the vast majority of the studies have shown that hyperprolactinemic patients on cabergoline are not at risk of valvulopathy, at least at the normal, sort of typical doses that we give our patients. And if we look back at this New England Journal of Medicine study at the patients who had the most significant regurgitation, they received high cumulative doses of cabergoline. And if we look at the patient I presented and calculate how long it would take her to reach that level, it's 309 years. So we could reassure her that it's not a problem. And now, these many years later, she's still on cabergoline and doing well. So I'm going to shift gears now from the most common disorder to one of the rarer disorders, and that's acromegaly. Just a reminder that acromegaly is produced in pulses from the pituitary gland in response to stimulus from growth hormone releasing hormone in the hypothalamus and inhibition from somatostatin from the hypothalamus. So it's the interplay of the positive stimulus and the inhibitory stimulus that results in the net production of growth hormone. This then travels throughout the body to the many target organs like bone, fat, and muscle. And liver is a big target organ for growth hormone because it's in the liver that insulin-like growth factor is made in response to the pulses of growth hormone that are flowing by. So let me tell you about this man. He's a 45-year-old man who was referred to an endocrinologist right near us in Boston because during a series of pre-op lab draws for his planned bilateral carpal tunnel release, he was found to have diabetes. So this was a new diagnosis of diabetes. So the surgeon said, I can't operate on you yet. Go see the endocrinologist about this diabetes you seem to have. And so the endocrinologist saw him and got a history that he'd had hypertension for 5 years. And on review of systems, he had joint pain, fatigue, He had recent erectile dysfunction that he and his PCP ascribed to an increase in blood pressure medicines. And he also had headaches, but he was kind of explaining them away related to stress at work. And so there you see him. He also had an increase in shoe size from 10 to 12 triple E over 5 years. And in the planning for the surgery, his wedding ring had to be cut off because they couldn't take it off. And there you can see his hand where there's extra fleshiness lateral to his nails. On exam, he had a deep, gravelly voice. You can see his broad nose and prominent brow. You can't see that he has new spaces between his teeth because his tongue has become very prominent and kind of filling up his mouth, so that he actually noted that people were having trouble understanding him, and they'd ask him to repeat himself because his tongue was kind of interfering with his speaking. He also had thick palms and soles, skin tags, and an enlarged thyroid gland. So unlike prolactinomas, which are more common in women, also true of Cushing's, which I'll talk about next, acromegaly is kind of an equal opportunity disease with equal representation by men and women. You can see men in the bars that are green and women in yellow here. And it's very rare, about 3 or 4 cases per million population. So you may again say to yourself, if you're not an endocrinologist, why should you care? And the answer is because this disease kills people. Here you see the probability of survival over a quarter century in a healthy population. As time goes by, of course, people are getting older and dying. Oops. But if we look at patients with acromegaly, they have a lower probability of surviving, or if you put it the other way, a higher mortality rate. And if the acromegaly is associated with diabetes, as it was in this patient I just told you about, it's worse still. And if the acromegaly is associated with cardiac disease, which is common with valvulopathy because the heart gets enlarged, there's an even more serious risk of mortality. What are the causes of death? You can see them listed here. Cardiovascular in men, cerebrovascular in women, respiratory. There's a lot of sleep apnea in these patients, and perhaps malignancy. It certainly increases the risk of colon polyps. And here's a diagram that just shows you how many different parts of the body are impacted by acromegaly. So you can think about what is your special interest, what is your specialty area, and I bet it's impacted by acromegaly. Here are kind of the big 5 things we think about: hypertension and heart disease. There are cerebrovascular events and headache, lots of arthropathy symptoms with arthritis and vertebral fractures. We already talked about the diabetes and sleep apnea. But the good news is that if the patient can be diagnosed and treated, their mortality rate can actually go back to normal. So we looked at the impact of normalizing IGF-1, which is kind of the biochemical marker of growth hormone excess. And we found that patients who were not in remission, meaning they still had an elevated IGF-1 despite surgery or medicine or radiation, still had a higher mortality rate than normal. But in the patients who were normalized through any means, surgery, radiation, medicine, or all 3, had a normal survival. And so this is the reason it's so important to make the diagnosis. And also, patients, besides mortality, have a lot of morbidity that can get better with treatment. And so we really want people to be diagnosed and treated early. How do patients typically present? All patients, virtually, nearly 100%, have enlargement of their hands and feet from soft tissue overgrowth stimulated by growth hormone. But people don't go to their doctor and say, I've had enlargement of my hands. And in fact, notice that the 3rd thing here is menstrual disorders. So for women, going to the doctor if you have disrupted periods is something that you sort of know to do. And that's one of the more common reasons that patients are diagnosed, because they go in with a menstrual complaint and are found to have this condition. Sort of indirectly, the patient I presented to you fits that he was found because of his carpal tunnel syndrome, because it was the blood test that led to the finding of diabetes, both of which, of course, are listed here, that brought him into the medical system. But in fact, 40% of cases of acromegaly are diagnosed completely by chance. The patient wasn't seeking medical attention, and yet they were diagnosed. Now we have 30 minutes left. I could actually spend the 30 minutes just telling you stories of how that happened. I think, though, I'll just tell you one. So let's see. I'll pick the painter. So there's a outdoor, outside of your house painter who was married, and his wife was expecting their first baby. And he had not met the obstetrician who was going to deliver the baby because he was busy, painting houses when she would go see the doctor. But one day it was pouring rain in Boston, and he couldn't go do the painting. So she said, "Why don't you come with me? You can meet the doctor who's going to deliver our baby." He said, "Sure." And he went with her to the doctor's office. Now, I've heard him tell this story a number of times because we have him go to Harvard Medical School and teach the students, and he's an amazing storyteller. So I'm not doing justice to his great way of unfolding this story. But what he says to our students is, so picture this. He's a very big guy, acromegaly. I go into a waiting room, and there's like 8 or 10 women there. I'm the only guy. I sit next to my wife. I try to look small. I try to melt into the background. And the doctor comes in and comes over and shakes my wife's hand, and she says, "Oh, I'd like you to meet my husband. He's here today with me." And the doctor shakes my hand, and then he looks at my wife and he says, "Is it okay with you if I take him back first?" And he says to the students, "Here it's a doctor who only sees women. What does he want me in the office for? What does he want me in the office for?" And so when he describes this, what he tells us is that actually the two of them went back to the office, and the doctor had noticed that his hands were fleshy and warm and very sweaty, and looked at his face and saw the typical features. And so he needed to take him privately and ask him some questions. And in fact, as the patient recounts the story, he was a little unsure at first, but every question he was asked, "Do you snore at night? Do you have joint pains?" The answers were all yes. And so he let the doctor continue and ultimately came to us and was diagnosed. And we still see this patient, and he gets to teach the students, which is so fun for the students. But that's just one example of how accidental the diagnosis can be. So if it hadn't rained that day, when would he have been diagnosed? And I tell these stories because it means if you see a patient, a person even on the street who looks like they have acromegaly, it's really important to say something because that might be their only chance to be diagnosed. So think about the fact that there can be changes that are very gradual in the forehead, in the lips, in spacing of the teeth. The person on the right has acromegaly in this picture. You can see her hands are much fleshier. And yet it takes up to 15 years to make the diagnosis of acromegaly. So after the symptoms have started. So why does it take so long? Well, I think there are a lot of reasons. For one thing, it's a rare disease. I mean, I won't put you on the spot now, but think about how many times did you hear about acromegaly in medical school? I'm guessing that if you did it all, it was for 2 or 3 minutes, right? And so rare diseases that we hear about once are hard to keep in front of our mind when we're seeing patients with lots of common conditions and need to take care of them. Also, the symptoms are extremely nonspecific. So if I were to say to you, "I'm having crushing chest pain right now, radiating down my left arm and up into my jaw," you would all say, "I'm having a heart attack." Sure. So that's a specific, very specific set of symptoms, and even patients know that that means you need to go to the doctor. But if you have some joint pain and your ring is a little tight, you don't necessarily think about going to the doctor. And I told you that my patient had new erectile dysfunction, but he and the doctor had an explanation for it. And he had new headaches, but he had an explanation for it. He was under trouble at work. He was under stress at work, rather. And so patients just explain it away. And the third reason is how gradually the changes develop. It's a very slow, very insidious disease. And so one way I'd love to illustrate this is a page from an Endocrine Clinics of North America chapter by Mark Molich, an endocrinologist who recently retired at Northwestern. And if you look at this person who has acromegaly in 1988, it's very clear. She has the broad nose, she has kind of coarsening around her eyes, the full lips. I think it's pretty easy to see that there's a big change compared to 1977. But if you look at her in 1981, I think she already has it then. Look at the difference in her lips. Now, if you're wondering how is it that Mark Molich had all of these pictures that were sadly chronicling the history, natural history of undiagnosed acromegaly, she was a school teacher, and these are yearbook photos. So we took a look, my colleague Lisa Noctegal at Mass General took a look at who makes the diagnosis of acromegaly, since it's so hard to make. And 44% of the time in the series she looked at, it was a primary care provider. So kudos to the primary care providers. I'm also married to one, so I have to say that. But endocrinologists are only 13% of the time. Look at all of the other people, including patients who thought maybe they had this condition. Neurologists, dentists, ophthalmologists, a host of other people think about this diagnosis. And within medicine, look at all the specialties, GI, pulmonary. So we have to be on the alert. I have been referred patients by gastroenterologists who were puzzling over the fact that they just finished a colonoscopy and someone who is very young and has no family history shouldn't have colon polyps. And then they finish the procedure and the patient sits up and they look at the face and they say, I know why you have this. You need to go see my endocrine friends. So the hardest part of making the diagnosis of acromegaly is actually getting someone to think about it. Making the diagnosis is not so hard. However, this is a problem of too much growth hormone. So you would think, let's just measure a growth hormone. That's the wrong test. And here's why. This is a graph that shows you growth hormone levels measured every 10 minutes for 24 hours on a clinical research center. Let me know if you want to volunteer for our next study. And have 145 samples of blood drawn over 24 hours. And what you see here is that during the daytime, 9 a.m. until the nighttime, there's only a couple of pulses of growth hormone. Whereas most of the day, there's really no growth hormone being made at all. And at night, as soon as the person goes to sleep, which is depicted here in the yellow bars, the big yellow bar, as soon as the person goes to sleep, this is a man, as soon as he goes to sleep, he starts making huge pulses of growth hormone, and he has 4 big pulses during sleep. This is why when my now adult children were resisting going to bed, I would say, you need to go make some growth hormone and grow big and tall. Now, there was a lot of eye rolling, but the boys are over 6 feet, so you never know. Anyway, we did the same protocol on a patient with acromegaly, and you can see that it's chaotic. It's up, it's down, but it never really goes to a consistently undetectable level during the day. And I would argue that the beautiful, smooth pulses are music, and that this chaotic pattern is really noise. But the reason I'm showing you this is the following. If you sent the healthy volunteer and the man with acromegaly to the lab, at any of the times I've circled in green, the levels are exactly the same. Measurement of a very pulsatile hormone is not useful because you don't know if it's the highest they've been that day, the lowest they've been that day, on the way up, on the way down. We don't do that. So what do? We measure IGF-1. IGF-1 basically gives us the area under the curve of the last 24 to 48 hours of growth hormone secretion. It kind of integrates all of those pulses because all the pulses are flowing by the liver, and that results in the net production of IGF-1. And so for those of you who maybe aren't an endocrine fellow, when you take the boards, this is the best screening test for acromegaly. And so we did an IGF-1 in the man I showed you, and you can see that his level is extremely high. It's nearly 1,500. And we do another test. One of our rules in endocrinology is if we think a hormone's too high, we try to suppress it And if we think it's too low, we try to stimulate it. And so in the case of acromegaly, we try to suppress it. And glucose suppresses growth hormone. So just like a pregnant woman takes a glucose test, we do that in patients with acromegaly. And in a healthy person, the growth hormone level will shut off. It'll be less than 1. In his case, it only went to 10. And so that tells us he has autonomous production of growth hormone. We can't suppress it the way we could in a normal person. Notice he also has a mild elevation of prolactin, and he has a frankly low testosterone, which suggests it's not the blood pressure medicine that's causing his erectile dysfunction. He's hypogonadal. And so the next step is to get a head MRI. And this wasn't subtle. He has this big tumor here that you can see. And you can't even see his optic chiasm, and it's extending into the right cavernous sinus. That's the carotid artery on the right and the carotid artery on the left. It's kind of pushed them apart and widened the sella. And he did, in fact, have some subtle visual field loss superiorly from compression of the optic chiasm. And so the next step is very obvious, and the guidelines that have been written both by the Endocrine Society and the Pituitary Society all say the same thing, and that is that pituitary surgery by an expert pituitary surgeon is the initial treatment in virtually every patient with acromegaly. And in his case, there's no question because he's losing his vision from compression of the optic chiasm. And so the surgeons go through the nose and through the sphenoid sinus, but it's a little more complicated than these diagrams. Here's an actual picture of our expert pituitary neurosurgeon. He's looking through an operative microscope while he is manipulating the instruments that he can see through the microscope. And success of the surgery, and by that I mean taking out the tumor, leaving the normal pituitary and not causing other problems, is directly related to the expertise of the surgeon, what's called a volume outcome relationship. The higher the volume, the better the outcome. So he did have surgery performed, and his tumor stained for growth hormone as we would have expected, and it was a benign adenoma. His IGF-1 has come down by half, which is really great, and his glucose-suppressed growth hormone is now suppressing to 3, but that's still abnormal. So he feels better, his visual fields improved, his rings and his shoes are looser, he has less headache, and he feels well, but he still has acromegaly. And you can see that there's residual tumor there around the right cavernous sinus, around that carotid artery where it's not really safe to operate. And so he needs further treatment. So I'll just say that the endocrinologists here are very familiar with all the various treatments. We've had kind of an explosion of medications over the last few years. Pasiriatide, oral octreotide, and paltusotine are all new in the last decade. And so it's great because we have different options that we can offer to our patients now. In his case, he was started on one of the somatostatin analogs. Once again, the concept of mimicking the natural inhibition of growth hormone from the hypothalamic hormone somatostatin. Somatostatin also is very short-lived, so you'd have to walk around with an IV. So somatostatin analogs have been developed to inhibit growth hormone. And they've been developed actually to be able to be given just once a month or orally. There's a lot of options now. In response to the monthly injections, his diabetes completely resolved, his hypertension resolved, and his ED and his headaches went away. So all of the things that had been explaining away these symptoms were wrong. It was all the acromegaly. And once it was treated, he was able to no longer have any of those problems. So I'm going to finish up by talking about my favorite disease in all of medicine, not just internal medicine, but all of medicine, which is Cushing's disease. So just a quick reminder about the system that controls cortisol production. Corticotropin-releasing hormone in the hypothalamus travels down the pituitary stalk to reach the pituitary and thereby trigger production of adrenocorticotropic hormone, ACTH. That circulates to the adrenal glands and results in production of cortisol. And then cortisol travels throughout the body to glucocorticoid receptors. There's a feedback inhibition as cortisol rises. It shuts off CRH and therefore ACTH and therefore cortisol production. And that goes on all day and all night. Just a few quick definitions. Cushing's syndrome just means all of the troubles associated with having too much cortisol. And by far, the most common cause is us. We give steroids for everything. Bee stings, poison ivy, lupus, you name it. We give steroids. We give them orally, we give them topically, we give injections. And that's exogenous Cushing's. But that's not what I'm talking about. I'm talking about endogenous Cushing's, which means too much cortisol from a tumor within the body that's either overproducing ACTH, like a pituitary tumor, or an ectopic tumor that acts like a pituitary, or a tumor on the adrenal gland that's directly producing cortisol. So these two are called ACTH dependent. The problem is too much ACTH. Whereas a tumor on the adrenal is ACTH independent. It's not ACTH's fault. It's not the pituitary's fault, so to speak. When Harvey Cushing first described this condition in the 1932 bulletin of the Johns Hopkins Hospital, he was describing a group of patients, mostly women, who had the physical features of Cushing's, and he found that they had corticotroph tumors in their pituitary gland that looked basophilic under the microscope with H&E staining. And so the paper was entitled Basophilic Adenomas of the Pituitary Gland. And that's why, if it's a pituitary source, it's specifically called Cushing's disease, the disease named after the neurosurgeon who described it. Whereas Cushing's syndrome just means too much cortisol and its effects. So some fun facts, it's also rare, much more common in women except in pediatrics. About 75% of cases are in women. It's nearly always benign, but just like with acromegaly, it has very high morbidity and increased mortality, and yet, if we treat it, those can go back to normal. When Harvey Cushing first described this condition in 1932, 50% of patients died in 5 years. Now think about the fact that these are healthy young women otherwise, in their 20s, 30s, 40s, dead in 5 years. And 20 years later, plots published about this again, and the death rate was still 50% in 5 years. That's pretty devastating. Now, in the 70s and 80s, bilateral adrenalectomy became the primary therapy for Cushing's. Now, the adrenals, remember Cushing's disease is a pituitary tumor. The adrenals haven't done anything wrong, but if you take them out, there's no more cortisol. And so for a while, that was the treatment of choice. The survival improved to about 80%. In the current era where transsphenoidal surgery is the primary therapy, we have been able to restore mortality back to what it should be, assuming that the diagnosis is made. So let me tell you about this patient we saw a few years ago, an 18-year-old college student in Western Massachusetts. She was admitted to the psychiatric hospital there because she made a suicide attempt. This was attributed to the fact that she was depressed and it was thought to be because she'd never lived away from home before and college was stressful. And the psychiatrist who admitted her to the hospital took a detailed history and noted that she'd had 4 months of amenorrhea, for which she had gone to the college health service and they had given her birth control pills. It's pretty common to have amenorrhea when starting college, so that wasn't so unusual. She also had weight gain, freshman 20. She also had bruising. And the psychiatrist raised the question as to whether she might have Cushing's syndrome. So he did an overnight 1 milligram dexamethasone suppression test, that same concept, to try to shut down something that might be high. And the cutoff for normal suppression is less than 1.8, and she failed to suppress. So he thought, wow, I might have a case of Cushing's. So he called the internist who was assigned to the psychiatric hospital. And the internist said, no, depression raises cortisol. I don't think this is Cushing's. You should know that depression raises cortisol. You're a psychiatrist. That is a true statement. Serious endogenous depression can raise cortisol. So how do we figure out if a patient like this needs to be worked up? Well, the first thing we have to do is think about whether they have pathologic cortisol excess. And only if they do, then we look for whether it's pituitary or adrenal ectopic, because the treatment is usually surgical. So we need to know where the problem lies. So thinking about how to make the diagnosis, we always start with clinical features. And here again, you see this is a disorder which impacts so many different organ systems. One of the reasons that this is my favorite disease is that over the decades that I've had the pleasure of helping patients with Cushing's, I have been referred patients by every single specialty in medicine, all of medicine, not internal medicine, well, except one. So you could name a field, and I can tell you a case of how that orthopedist or that urologist or that radiologist referred me a specific case. So it really impacts the entire body. It's quite dramatic. But who does think about the diagnosis? We had the chance to collaborate with a patient support group and gave them a survey to ask who was the first person to say you might have Cushing's. And of course, it was a doctor a lot of the time. That's the big piece of blue pie here. But notice that the patients themselves sometimes thought of the diagnosis, or a friend or family member, a nurse or nurse practitioner or PA sometimes made the suggestion to be evaluated. And notice this small sliver here of teal, someone with Cushing's went up to them and said, I think you might have what I have. So that was pretty interesting. And then we looked further into which were the physicians, which subspecialties. And once again, the PCPs win out. The PCPs are the ones who thought of it first, followed by endocrinologists. And again, we see nurses, hospitalists, hematologists, ER doctors, and then, as you see at the bottom, a host of other specialties were the first people to suggest that the diagnosis be made. Now, sometimes it's obvious that someone needs a workup. These patients look floridly Cushingoid. There's wide stretch marks, there's bruising, there's hyperpigmentation. So in people like this, your first thought is they must be taking steroids. But if they're not taking steroids, then a workup is indicated. It's not always so easy, though. This is a patient who was a tax accountant and was having a lot of insomnia, which she didn't mind in February, March, and April because it let her stay up and do more tax returns. But she came to see us in May because by then she was exhausted and still couldn't sleep. So how do we tell if a patient like this needs evaluation? Well, there are signs that are not predictive. That is, they occur in Cushing's, but they don't raise the possibility of a patient having the disorder. And you see those on the left. Just the presence of obesity or hypertension or plethora doesn't raise the probability of a person having Cushing's. But in patients who have spontaneous bruises or wide stretch marks or osteoporosis at an earlier age or in a man, unprovoked hypokalemia, or if the pattern of obesity is central with thin and weak arms and legs, we should do that. And the other thing we like to do is what we call a photo album biopsy, the only procedure in neuroendocrine, which we haven't figured out how to bill for, by the way. This shows that patient just a couple of years earlier. So she's clearly changed. What about the young woman in college? We asked her to bring in an old picture. These are just 6 months apart. Now, granted, she's all dressed up on the left. It was the day of her prom from high school. But I think even with her hair in the way, you could see that her clavicle was visible here, and now she has supraclavicular fat, classic for Cushing's. And so these people do need to be diagnosed. And what are the tests we do? If there's only one thing you remember from my hour with you, please remember this. Look at the screen. Resist the urge to measure a serum cortisol. And you know why now. Here is a curve of a healthy woman, and here is a curve of a woman with Cushing's. And if we send them to the lab at any of the times I've circled in green, the level is the same. A single value of a pulsatile hormone isn't helpful. So what do? Our guidelines say measure at least 2 late-night salivary cortisols because cortisol also has a diurnal rhythm, but opposite from growth hormone, so it should be undetectable at night, or 2 24-hour urine collections, or 1 milligram overnight dex suppression test. And then if they're abnormal, we have to think about all of the causes of false positives, like depression, alcohol use disorder, and many other things. Interestingly, guidelines are not being followed. This is a study that asked what was the first test in a patient with Cushing's that was or suspected of Cushing's. The green portion of the bar is serum cortisol. Almost all the patients, 80%, were screened that way. Urine-free cortisol, you can barely see the purple and the green, which are late-night salivaries. Sorry, the orange that are late-night salivaries. So spread the word. Teach your colleagues not to do serum cortisol. In terms of this patient, her diagnosis was easy. She had an extremely high urine-free cortisol on a number of occasions. So the diagnosis has been made, and we have to figure out where it lies. In her case, it was easy because the subsequent tests we did showed that the ACTH was coming from the pituitary gland. And therefore, the treatment, which is surgical, according to the guidelines, is exactly the same as acromegaly, surgery by an expert surgeon. So she did have that surgery, and an adenoma was found and stained for ACTH. And after surgery, because we've removed the tumor, creating too much ACTH, all that's left is the normal gland, which is shut down. The corticotroph cells are turned off because they've been exposed to too much cortisol. So now she's adrenally insufficient, and she needs to take glucocorticoids until the system wakes up, which takes on average a year. And she made a very dramatic recovery. Her depression resolved. She came off her depression meds, and here she is several years later. And so this is another reason that I really love Cushing's, because patients get better. So in conclusion, consider growth hormone secreting tumors in patients who have clinical features. With the exception of prolactin, don't measure the hormone because it's pulsatile. Acromegaly and Cushing's are deadly diseases, but if they can be diagnosed and treated, patients do very well. And we have lots of new treatments available if surgery doesn't do the trick to help control our patients. And I think I hope have convinced you that it may take a long time for the diagnosis to be made, but if you think someone might have one of these conditions and you're not an endocrinologist, get some help from the great group here. So I'd be glad to take any questions that you might have, and also invite you to our endocrinology course if you'd like to join, which is virtual every spring. Thank you. Yeah.
You know, when you look at how difficult it is to pick these rare diseases up, is there some role for us to think about our patients who may be higher risk with diabetes or sleep apnea, that maybe we do routinely look for to have them bring in photos, or we periodically do an IGF-1 or something every few years on people with hypertension and diabetes, or some reminder to look for it in some way to put in the systems.
Yeah,
that's an approach to screening for them, because it's so difficult. And you know, the ones that I've seen with Cushing's, or particularly acromegaly, years they've had it, and it's and you look at the man there, it's so obvious he has it if you've seen it before.
Yeah, it's a really important question, and the NIH actually addressed this in patients with obesity. So they asked the question, should all patients with obesity be screened for Cushing's? And the sort of distillation of their report is no. It's not cost effective because too many Americans are obese and don't have Cushing's. But your ideas have been sort of bandied about but not carried out. One other idea was going to extra large shoe stores and handing out pamphlets that if you need a size 12 triple E shoe, maybe you need an IGF-1 too. I think that we haven't gotten to that point, but I think it's the right thing to be thinking about. And at least, I think we can't screen everyone with sleep apnea. But if patients with sleep apnea have, say, maybe 2 other things, that would be worth doing. And there's some work being done now in Europe looking at whether artificial intelligence can provide guidance. In other words, screening faces to try to pick that up. So there's several trials that are ongoing to try to use AI visualization to make the diagnosis of acromegaly. So I think we're not there yet, but I think it's a really important question, and we should work towards finding sort of a constellation of things that should make us trigger a workup. Yeah.
Quick question.
question basically because I have one Cushing's disease patient, and based on your presentation, you said usually it takes about a year for the axis to recover. Is it common to, or is it normal to see somebody recover the axis in about 2 months?
Yeah, that's a great question. So it takes on average 1 year if the patient has pituitary Cushing's. If they had surgery for adrenal Cushing's, it's been shown that it can take up to 2 years. But your patient had Cushing's disease. And so the answer is if someone recovers their HPA axis within 2 months, I am very worried that they're having a recurrence. Yeah.
So we screened him for recurrence and his salivary cortisol, urine-free cortisol. I know saliva is the first one.
Saliva is the best test. So good job. That was the right
It's
test.
still negative, but I'm still nervous for him.
Yeah,
But he's
so
clinically looking like there is resolution.
great.
Mm-hmm.
A recurrence can take a long time. It can take 6 months, a year, 3 years sometimes. So you've done the right things, but I would say don't stop doing them. So maybe every 6 months, every year at the most, have him do 2 more late night salivaries. And also let him know that if he thinks he has the symptoms coming back, he should come in sooner than his next appointment. A lot of patients with Cushing's recurrence know it before we do. And I used to tell patients, they would come in and say, I think this Cushing's is back. And I'd say, why? And a lot of times they can't even articulate it. It's like, well, I have a concentration problem. Or, well, I was snapping at my kids more than I used to. Or, well, I couldn't, I had insomnia. Sometimes they can't even explain. It's like it felt before is what they say. Well, I used to, 100 years ago when I was a fellow or junior faculty member, all we had was urine-free cortisol. So I used to do urine-free cortisol, and they'd be negative, and I'd say, no, you're fine. And then they'd come back with clear-cut Cushing's because, as you've alluded to, we have data from France that show us if you follow people who recur, the first test to become abnormal is late-night salivary, loss of diurnal variation. The second test to become abnormal is 1 milligram overnight dex test. And the last test, which can take more than a year from the onset of recurrence to become abnormal, is 24-hour urine-free cortisol. And so I think you're doing the right thing, but just let the patient know to contact you if he thinks he has it back. And in the meantime, do at least annual late-night salivaries. Well, I think the time is up, so thank you for your attention.
Thank you. If you want to join us, we're going to do a